We wanted to get people who are involved in providing IMHA services, but particularly the people who commission IMHA services, together to start thinking about what products could help them raise quality and increase access to independent mental health advocacy services.
What does good look like? I really hope that you're thinking about how IMHA services can ensure they match the diversity of the patients in a way that meets the circumstances of each patient.
I'm a service user, doctor, and I want to get some fresh air. You know, that's the starting point I want to suggest, and then I want to learn and I want to know how the system works to help me get out of that situation.
A litmus test isn't all this about our quality indicators or research. It's exactly as you framed it. Getting involved in decisions around care and treatment. And you that
mental health professionals don't necessarily understand what IMHA services are about. And therefore, they're under a duty through the Mental Health Act to promote access, but they might not be doing that because they might think wrongly that it's just for people who lack capacity to make decisions rather than being for everybody. So, in effect, gatekeeping happens so that only some people get through, and it tends to be those people who know what advocacy is.
we interviewed over 30 people who qualified for IMHA services but hadn't used them. And when we said to staff, well, why isn't Julie using the IMHA service? They said, well, you know, it's a choice. You know, that's her choice. That's what advocacy is about. When we asked Julie, she said, isn't it part of the mental health service? Or I might get into trouble if I use that, or isn't that the way you make a complaint?
The challenge for commissioners is actually collecting information on the difference that it's making to people's care and treatment under the Mental Health Act. So are they involved in key decisions about their care and treatment? And that's really the difference that IMHA should make. It's not just about people getting information about their rights, but it's actually changing the care and treatment so that they properly get the treatment they need, the support they need, and their needs met.
The way in which people are told about IMHA services on wards is in a significant minority of cases just not adequate at all. So we were finding wards where there may be a poster up or leaflets available, but very little proactive attempts to tell patients about advocacy, to encourage people to go to advocates, and to deal with patients perhaps who haven't got the capacity themselves to make decisions about advocacy, to refer those. What I'd like us to be able to do is to have some sets of basic expectations which are not as basic as they are at the moment, so that we could actually look to having some sorts of quality standards that we could hold people to account for.
Be a difference between theoretical direct access and actual.
What we have here today is a fantastic group of people from different perspectives. So we've got commissioners, we've got carers, we've got service users, and I think from the discussion that we've had, we've learned a lot.
Co-production is about developing more equal partnerships between people who use services, carers and professionals.
There's no duck in the fact, is there? It's about a shift of power.
Yes, it's about transformation.
I'm always astonished at how slow we are in the public services to actually build and design services around the client, to involve the client in the design of the service. I think by doing that more we could save money, we could get services that are more effective, and we'd have more ownership from clients of the services that we provide. I hope people at the end of this will be much clearer about what good looks like and how they get from where we are today to good. I hope that there will be much more co-production in all of that.
We haven't had different meetings in different rooms to those other stakeholders. So from even the development of the strategy, including people sitting around the table that were organisations that represent users, but we're also individual users. So I suppose it's from the very beginning that we start that journey, and people will be involved to the end of it.
It's all absolutely vital that people are heard and represented.
We have commissioned an opt-out service so that people have a right to an advocate, because we have jointly commissioned with an adjacent council and with the NHS. We've made great efficiencies, and in effect uptake has increased massively.
Today was a fantastic way of listening to the end users and the commissioners and service user involvement and the advocacy providers to find out what isn't working so well, and importantly some of the ways that we can improve that. So I found today really useful in getting some of those ideas.